Thank you for attending this session. My name is Jaewon Lee. I will moderate this session. We have a distinguished panelist, Dr. Yongnak Jo, and yes, I will introduce my co-moderator. Dr. Takashi Akasaka is a well-known, famous Japanese interventionist. Dr. Jang Lee, Dr. Jongnam Pam, and Chien Boon, and Dr. Chris Ong. So we have 5 cases for this session. So because we have limited time, so 10 minutes for one case. So case presentation should be completed in 5 or 6 minutes. So for the next 4 or 5 minute discussion. The first case will be presented by Dr. Rin. I wish I had done it before TAVR osteal RCA intervention with rotablation of a calcified region and THB stent obstruction. Dr. Rin, please.
Thank you. Good morning, moderator and panelists. I'm Dr. Huan Chunlin from Zhengxin General Hospital, Taiwan. Today, please allow me to share a case I wish I had done before TAVR. Would you perform PCI to this kind of osteal lesion before a TAVR procedure? And this thing may become the thing I regret most last year. A brief summary for our patient. She's a 90 years old female with a TAVR procedure in 2021 because of severe aortic stenosis. And she also has stenting history to circumflex artery due to coronary artery disease. She suffered from shortness of breath and after related chest tightness since a few months ago, and it could be relieved by resting and sublingual nitroglycerin. Her baseline transthoracic echocardiography demonstrated her LV and RV function was preserved, and the valve function was well with mean pressure gradient only 8 millimeter mercury without any valvular erectile regurgitation nor paravalvular leakage. A cellular myocardial perfusion scan showed septal and inferior ischemia. So this is her angiogram before the TAVR procedure. You can see the tortuosity of left main and right coronary artery, and the circumflex stent is a patent. And this is her right coronary artery before TAVR. You can see on the aerial view show there's an osteal lesion with about 70 to 80% stenosis at osteal with calcification. But at that time, we choose to deploy to treat her aortic stenosis first. This is her final aortogram after the TAVR procedure. As you can see, the left main ostium and the RCA ostium were all patent at that time. So this time, because of recurrent angina, we performed the coronary angiography again. And you can see here, now the osteal lesion has progressed. This is an eccentric osteal lesion with calcification, and there are also 75% proximal segment stenosis. Because of the gel by the valve stem frame, we could not engage by the normal guiding catheter, so we use fishing wire technique and then guide extension catheter for selective engagement. Lesion preparation was done with 1.0 and 1.5 semi-compliant balloon, followed by 2.0 and 2.5 non-compliant balloon. However, the steel film confirmed it was a balloon undilatable lesion. And also, the IVUS cannot cross the lesion. So we decided to perform the rotational atherectomy. We start from 1.25 burr, and it across the lesion under the second attempt. Then we use a 1.75 rotabur to further debugging the lesion. And then we use the 2.5 semi-compliant balloon, and it delayed the lesion successfully. So we introduced our guide extension catheter to proximal RCA by using balloon anchor technique. And the IVUS show there's a fibroaceroma at the proximal RCA, and you can see a calcium nodule near the ostium of RCA. Between the junction of RCA ostium and the valve stem frame, you can see the reverberation, which could be the ring calcification or the TAVR stent strut. So for the stenting strategy, we decided to deploy the first stent 3.5 and 38 millimeter length drug-eluting stent from proximal RCA to the ostium of the RCA. And we deploy a second stent to overlap with the first stent. As you can see, the stem boost image. With the second stem was 2 to 3 meter protrusion into the transcatheter heart valve, and the overlapping region was located at the ostium and the junction of valve stem frame. We think this may increase the radial force of the stent and to avoid the further stent compression. So this is the post-stenting IVUS. You can see the suboptimal expansion at the proximal RCA, osteal RCA, and the junction of valve stem frame. So post-dilatation and part was done with the 4.0 non-compliant balloon. And this is our final IVUS. There's still suboptimal expansion at the osteal RCA and the valve stem frame junction, but we think this is a restriction of the calcium nodule and the valve stem frame, so this could not be done furthermore. And this is our final angiogram. You can see the ischemic flow and the distal myocardial blockage is very good. So in this case, we prefer this is a late delayed coronary obstruction according to Dr. Jaber in 2018 JACC article. This patient has several anatomic risk factors. Pre-TAVR CT analysis showed her coronary osteal height was relatively low, which is 10.6 millimeter of left main coronary artery and 11.1 millimeter for her right coronary artery. Besides, as you can see, there's a heavy calcification lesion at the RCA ostium for pre-TAVR CT analysis. And she also has a relatively small sinus of Valsalva, which average diameter is less than 28 millimeter, which is a high anatomical risk factor for delayed coronary obstruction. Late delayed coronary obstruction etiology can separate to two major categories. In this case, we prefer it is the fibrosis and endothelialization, which caused by the regional turbulent flow after the valve deployment and induce the fibrosis, local inflammation, and finally induce the endothelialization. The thrombus on the TAVR valve with the embolization is not a possible etiology. However, in our patient, she's not present with acute coronary syndrome, and she's on clopidogrel since 2019 because she put a DS in her second flex. So the thrombus possibility was less likely in this patient. In this case, the stenting strategy we call is orthotopic snorkel stenting, according to Dr. Bazzata, a published article in 2020. Unlike the classical chimney stenting, or you can call snorkel stenting, orthotopic snorkel stenting, which is more create a more physiological TAVR frame coronary stent configuration, which can promote, facilitate further coronary reconnection in the future, and may reduce the risk of coronary compression by the TAVR stent frame. So in summary, our case is a late delayed coronary obstruction, which is uncommon but serious complication after TAVR procedure. And the patient's late delayed coronary obstruction etiology may prefer the endothelialization. Not only the late delayed coronary obstruction, we also are from the coronary orifice calcification, and also the valve stem frame obstruction. So we conquer it with the fusion wire technique, guide extension catheter, and rotational atherectomy. Orthotopic snorkel stenting may create a more physiological stenting and a valve stem frame configuration and facilitate future coronary recanulation. Thank you.
Thank you for a nice presentation. It's time to discuss about this case.
Well, one of the problem here is actually the choice of the TAVI, not the choice of the other. Have you thinking of using a balloon expandable like the Edward, Edward valve instead of the Edward valve in the beginning? Then you don't have the problem.
Yes, the valve, choose the valve is a quite big decision, but there's some limitation for our center to achieve the balloon expandable valve at that time. So we only have the core valve at that time. But maybe we can choose another portico valve which have a valve, which have a bigger valve stem frame. The orifice is more bigger, may facilitate our future coronary recanulation. We have discussed in our division conference, and we prefer maybe we should choose another valve at that time. Yes.
Any other question? I think I think it's very important to find the position of ostium of RCA because there is TAVR valve, so you need a perpendicular plane view to find the initial point of RCA origin. Yes. So at the moment, I will use IBUS for location at the RCA ostium and rotational angiogram to find the exact origin of the RCA.
Yes, we use the rotational angiogram, but it's still kind of difficult to confirm the orifice at that time. Yes.
Okay. Do you have lithotripsy like a shockwave balloon in Taiwan?
Actually, our hospital just demonstrated the first lithotripsy just 2 days ago.
Yeah, this will be an ideal case.
Yes,
for
this
that.
will be an ideal case. But at that time, this is happening in August. We still cannot available the shockwave lithotripsy at that time.
Can I confirm, right? Because of the height of the coronary artery, did you select the evolute valve, right?
Yes.
Some risk of the coronary occlusion was concerned, right?
Yes.
I see.
Yes, the coronary issue is concerning this patient. I believe we should choose the balloon expandable valve, but it's some kind of non-medical issue in our hospital.
Before TAVR, it might be very difficult to confirm the ischemia in the right coronary artery sometimes, right? But in our institution, there are a lot of discussion. But before TAVR, if you try to do the PCI to the RCA, yes, it is another way, right?
Yeah, it's another way. Yeah.
Right.
So I think I will be very regretful for this patient. Yeah.
But at that time, actually, they have the functional scan. The thallium, actually, the right side was normal.
I see. Yes. But in aortic stenosis, it might be very difficult to get a clear defect in the some stenosis.
That's
right?
why the choice of the TAVI valve is important.
And therefore, I would like to recommend some wire-based physiological evaluation. Right.
Okay. Very nice, excellent presentation, Dr. Lin. It's time to finish the discussion. We'll introduce the next case.
Thank you.
Presenter is Dr. Lindon from Philippines. A case of critically confirmed COVID-19 in a 52-year-old Filipino male presenting with multiple coronary artery disease.
Okay. Great.
Thank you for the invitation. COVID hit our shores last March 2020 and is responsible for COVID-19 pandemic, causing higher thrombus burden in COVID-19 patients that can trigger acute coronary syndrome. Good morning. I'm Maria Antoinette Hilindon from Philippine Heart Center, and together with my consultant and operator, Dr. Ana Chua and Dr. Ronaldo Stasio, I will be presenting a case of critically confirmed COVID-19 in a 52-year-old Filipino male presenting with multi-vessel coronary artery disease. I have no disclosure, and this is my objectives. Presenting to you a 52-year-old Filipino male, unemployed, hypertensive, diabetic, with prior history of stroke last 2016. 24 hours prior to admission, the patient presented with sudden substernal chest pain, non-radiating graded 9/10 in severity, accompanied with dyspnea and shortness of breathing. Hence, patient was rushed to the emergency room. Upon arrival, he was received hypotensive, drowsy, with desaturation. IV fluid, medicine, and O2 supports were started. A 12-lead ECG was done, which showed a sinus tachycardia, inferior wall infarction with posterior wall involvement, and a right bundle branch block. Our initial assessment is a hypertensive atherosclerotic cardiovascular disease, coronary artery disease, acute coronary syndrome, ST elevation myocardial infarction, inferior wall, Killy-4 in sinus rhythm. A chest X-ray was done, which showed a right lower lobe pulmonary edema, cannot totally rule out pneumonia, and a SARS-CoV-2 gene expert positive result. Patient was brought to cath lab with baseline BP of 104/69 and a heart rate of 80 beats per minute. A left heart catheterization and coronary angiogram were done by a percutaneous right transfemoral arterial approach using 6 French Judkins diagnostic catheter. This showed a 3-vessel disease with left main involvement. The left main coronary artery showed a fair-sized vessel with a 70 to 80% aorto-ostral stenosis. The left anterior descending artery is a good-sized vessel with a 95 to 99 proximal stenosis, followed by another 90% mid-segment stenosis. The left circumflex artery is a small-sized vessel, non-dominant, that is totally occluded at the proximal segment. The more distal vessel is visualized via the left to right collaterals. The right coronary artery is a good-sized vessel showing 95% proximal stenosis, becoming totally occluded at the mid-segment. Our assessment, coronary artery disease, a three-vessel disease with left main involvement, RCA as the culprit, and a syntax score of 41. Initially, balloon angioplasty of the right coronary artery over the culprit lesion was done. A guide wire was inserted and a 1.25 by 10 mm splinter Medtronic was inflated at the mid to distal RCA, followed by a 2.20 mm splinter Medtronic at the mid to distal RCA and a 2.20 mm non-compliant Mosaic inflated at the mid to distal RCA. Our final shot noted a TIMI-3 flow. Intraprocedural event was noted. Patient had hypotension, bradycardia, and persistence of desaturation. Hence, an intra-aortic balloon pump and temporary pacemaker was inserted. Patient was also intubated at that time. So we're presented with a diabetic patient with a multivessel coronary artery disease with left main involvement and a syntax score of 41. The plan is to do urgent coronary artery bypass. Hence, patient was referred to cardiothoracic surgery. However, since patient was positive for COVID-19 infection, a 21-day recovery period was recommended prior to the operation. On the second hospital day, patient went into a cardiac arrest and ACLS were activated with return of circulation after 4-epinephrine. The family now decided not to forgo revascularization. Patient was then managed medically with noted improvement thereafter. The TPI and intra-aortic balloon was then removed. On the 15th hospital day, patient again complained of chest pain, and the heart team decided to do a percutaneous coronary intervention. However, relative and patient refused. On the 16th hospital day, they consented for PCI. An intra-aortic balloon pump was inserted prior to the procedure since the patient is still on inotropics support. Percutaneous coronary angioplasty of the RCA was done via right transfemoral approach using a 7 French catheter. A guide shot showed that the RCA is a good-sized vessel, dominant with a 95% proximal segment stenosis, followed by a 95% distal segment stenosis. A balloon used, a 1.5 by 2.0 emerged Boston Scientific, was inflated at the mid to distal RCA, and a 2.0 by 20 mm emerged Boston was also deflated at the mid to distal RCA and proximal to mid RCA. Stents now were deployed using a 3.5 by 24 mm Promus Premier Boston Scientific at the proximal RCA and a 2.25 by 28 Promus Premier Boston Scientific at the distal RCA to RPDA, and a 2.78 by 28 mm Promus Premier Boston at the mid to distal RCA. Post-dilation was done. IBUS post-stent showed a well-opposed, an expanded right coronary artery with no residual stenosis. This is the final shot. Percutaneous transluminal coronary angioplasty of the left main and LAD were also done. So they initially, they do an intravascular ultrasound-guided percutaneous intervention of the left main and left anterior, and they showed a higher plaque burden. They tried to advance a balloon across the left main coronary to proximal left anterior descending. However, we noted heavy calcification at the proximal left anterior descending artery. Hence, rotational atherectomy was carried out using a rotawire flappy Boston Scientific of 1.5 mm. So, a balloon using a 1.5 by 20 emerged Boston was inflated at the proximal to mid LAD and a 2.0 by 20 mm proximal to mid LAD. A balloon also of a 2.5 by 20 mm non-compliant quantum apex Boston Scientific was inflated at the proximal to mid LAD. Stents were now deployed at the proximal to mid LAD using a 2.5 by 20 mm Promus Premier Boston Scientific at the proximal to left anterior descending artery, and a 2.75 by 38 mm Promus Premier Boston at the left main to proximal left anterior descending artery. Post-dilation was also done. at the proximal LAD. Intravascular ultrasound post-10 showed well opposed and expanded proximal to mid-left anterior descending artery with no residual stenosis. A successful IBUS-guided PCI of left main, LAD, and RCA with rotational atherectomy with Dimitri flow. COVID-19 pandemic has affected the standard of care on managing acute coronary syndrome. Patient with COVID-19 infection has an overwhelming inflammatory and catabolic state, and the recommendation for urgent coronary artery bypass cannot be done. Hence, exploring complex procedure, applying rotational atherectomy plus intravascular ultrasound technique is a favorable option for this complex case with multiple comorbidities and multivessel coronary artery disease involvement. The team has successfully revascularized the patient and weaned off from mechanical ventilatory and medical support. Patient was discharged improved and was able to follow up at our OPD with no subjective complaints. Thank you.
Thank you for nice presentation. Is any comment or question?
Yeah, congratulations, the very wonderful procedure, right? Yeah, at the time of COVID, this is, yeah, sometimes happen in the emergency ward, right?
Yes.
Yeah, could you teach me again the size of the left main stent?
2.75.
2 points.
2.75 for the left main stent.
2.75.
Yes, but 2.75.
It is not enough size for a left main. So I think much more ablation should be very important to try to put the bigger stent, right? So only the rotablator is 1.5?
Yes, the operator choose the 1.5 rotor.
I see, yeah. But it's complex case. It is very important to cure first, right? And then we have to think about the long-term follow-up, right?
This is a interesting case. I mean, unfortunately, because the guy got COVID. If he hasn't got a COVID, I think bypass is the best option for him.
Yes.
Yeah, so unfortunately, he had chest pain on the 16th day. One way of thinking is, why don't you just do a simple POBA for the right, because I think that's the source of the pain, and then wait 5 days for the cabbage. Because he's only 52 years old, you basically jacket the whole RCA and then put a very small stent for the left main. So the chances of his future cabbage is still quite high. So I think one way of doing it is just POBA the RCA, get the pain off the patient, and then do the cabbage about 5 days later for him. And that might be a more definite, because he got retrograde from the right to the third as well. So all three arteries are quite graphable. I think that is another way of doing it.
No,
Thank you.
Thank you, po.
Yeah.
Thank you.
All right. Thank you very much. Yeah. Okay, let's move on the third case, right? The lithotripsy to L6OM. This will be presented by Sanat Chivoin, right, from India, right? Please.
A very good morning to all of you. Thank you very much to all the moderators and to the organizers to give us an opportunity to present a case here. I'm Dr. Sanjat Chivane. I'm from India. What I'm going to present is a case where I have failed multiple times at multiple steps, multiple probably issues that I created myself. I could have probably done it in a much better way. But then I thought that it's worth presenting something that where you fail, but you still sort of succeed and come out of it. This is an old patient of mine, 72-year-old male, non-addict. Risk factors are elderly, Asian origin, morbidly obese, hypertensive, CKD. Had an extensive anterior wall MI in 2016. I did a primary PCI to LAD. He had a borderline SIR-CoM disease and an RCA CTO. He was advised that the RCA should be fixed, but he sort of refused it. He was having on and off rest and effort angina for about 1 month. He was optimized on medical therapy. He was advised a check angiogram, but like most of the Southeast Asians, he refused the same. Had dyslipidemia, raised troponins, creatinine of 1.6. Echo had a mild septal hypokinesia secondary to the old anterior MI which he had. this is the coronary angiogram. This is the right system, which was a proximal CTO, which was similar to how it was in 2016. The LED stent was absolutely perfect. The circ-OM disease had worsened. There was a tight osteoproximal disease, a small aneurysm just at the circ-OM bifurcation, the OM going down and dividing into two branches, and a fairly big-sized vessel. So the plan was that we'll fix up the circ first, and then maybe after another 6 to 8 weeks, we'll probably fix up the right. These are other views which show the LED and the spider view for the circ-OM origin. It looked absolutely fine. He had come in the morning as an elective case. Probably had some rest angina at night, and then I got him admitted. I thought it's going to be an easy peasy case. Started with the right transradial approach, conventional right transradial approach. Wired it with this is a 6 French radial sheath, 6 French XB 3.5 guiding catheter, a BMW wire. Pushed in a 2.012 balloon, dilated it. Then I thought that since it looks quite bad, I'll take down a Wolverine. The Wolverine refused to go. Dilated it in the proximal part, but it somehow could not go beyond the little aneurysmal part. Took a body wire, which was a Whisper ES, took a 1.510 balloon, refused to go down. Started thinking that there's something wrong, there's something that I'm missing here. Still dilated, kept on dilating. Took a 1.06 because I could not go till the distal part. This was with the help of a Geitzilla catheter, and then subsequently after the 1.0 went down, I took a 2.012, which somehow tracked down, and then I could make some space there. I thought that probably it's more or less solved. I'll probably be able to track everything down, because in the second video you can see that a balloon which was previously expanded could sort of go down very easily. Dilated again with higher size balloons with the help of a Geitzilla catheter. There was a little dissection just before the bifurcating OM. So I thought that probably I'm more or less now through. I should start stenting this entire segment. So then I tried taking down a stent. It did not go. At this point in time, I thought that probably I need to rework my strategy. I was still transradial, exchanged the wire with a Rota floppy, took a 1.25 burr, had some difficulty, but then it sort of went down. Didn't go very low as there was a small dissection down, and I don't want to sort of create further hassles for myself. Did couple of burring, and then I thought that looks good. Exchanged the wire back with a extra support, dilated the entire segment, and now the stent went down. This is a 2.5, I think 32 Resolute Onyx, which was deployed there. The second one created a little bit of issues, used a guideliner and somehow tracked it down. This is what it looked like. Looked good, but just beyond the native circ and the OM origin, there was some area which probably required further optimization. My balloons did not go down. The post-dilatation non-compliant balloons did not go down. So then I took a 212, took it down, and then I did what we call as a stent boost. And this is what the stent boost image looked like. An extremely under-expanded stent. This is at the point of overlap, and this is probably what was creating the problem for me. Exchanged the Whisper extra support with a BMW again, took a OPNNC 2.515 and went up to 40 atmosphere and broke it down, took a 312 IVL balloon and gave all the 80 shocks all across, optimized the entire segment with 2.75 and 3 millimeter balloon, and this is what it finally looked like. The stent boost images are there to the right. Take-home message: patients with obstructive coronary lesions with high calcium content, LHCC, have an exaggerated clinical risk, which we all know. I think early detection of intracoronary calcification, either with a CT angio or with an intravascular imaging, probably would have saved a lot of time, a lot of energy, a lot of finances that I probably end up burning in this case. Usage of Wolverine, OPNNC, rotablation, shockwave are synergistic, which is quite obvious in this case. Thank you very much.
Okay. Thank you very much. So this paper is now open for discussion. Any question or comment?
Yeah.
Yeah, please.
Yeah. Congratulations.
Thank you.
A good result. And sometimes rotor ablation result in bradycardia and slow flow.
Yes, yes, yes.
So I think, yeah, femoral approach is better. I think, just my opinion. Sometimes I experienced left main rotor ablation, no reflow phenomenon. At that time, patient is collapsed and
Yes,
even
absolutely.
cardiac arrest.
Yes.
So I usually prepare femoral approach and prepare temporary pacemaker, even ECMO.
Okay.
Yeah.
Point well taken. He had an RCA which was probably dependent from the left system, probably a bradycardia would have happened. But I think luck was on my side. You can see it quite obvious. Multiple mistakes made at multiple times, but still somehow, I could come out of it. So yes.
I mean, you did mention intravascular ultrasound here, but I didn't see you using it.
No, I could not use it. I did not use it.
Yeah, what's the reason behind? Because it might change your strategy completely.
One obviously was an inertia to use it because it was getting delayed. I should have probably used it at the early stage when my balloons were not going down. But I'm not sure whether the IVUS would have crossed through this particular segment which I showed you, the unexpanded area.
Once you rotor blade, I think it's the
It
best
would have
time
gone.
to IVUS.
Probably,
Yeah,
yes.
yeah,
Probably, yes.
You already noticed that very diffuse heavy calcification on the first angiogram. Why didn't you choose rotor ablation first?
I did not get your question.
So before balloon angioplasty, rotor first will be.
Probably would have been a better choice, yes. Probably, yes.
Yeah, this case is the very good indication for imaging, I think, because the tight lesion and also the aneurysmal change. I'm wondering just after the stent, even after you did a post-stent dilatation, still there are some aneurysmal. I think at that time, some under expansion or incomplete apposition at that portion, right?
Right.
The second thing is that this kind of stent under expansion should be expected during the balloon angioplasty. If the balloon undilatable region, maybe you can use 1 point or more bigger rotor valve for the more debulking of the mid-step.
Probably. I was going transradial, so I thought probably going with a 1.5 would be slightly difficult. Going through a 6 French catheter.
Yeah,
would
it's
probably be
1.5 is
difficult.
first of all, you can change the guiding catheter 7 French or C3 squiding or with a more bigger
Yes,
caliber.
yes.
You can apply 1.5 or
Yes,
1.75.
absolutely right.
Another way of actually doing the under expand stent is actually little tissue short wave.
Yeah.
Yeah, it's a very good technique actually. After the stenting, you still find the liquid ring situation.
I
of the
usually
calcium.
I use a lithotripsy in this case after the after with an OPN balloon.
Yeah.
First I opened it, then I
Yeah.
used a 312 lithotripsy balloon to
because-
expand it, and then I used a 312 and a 3.5
to open it.
to further optimize it.
Yeah. I think short wave will be a very good idea
Yes.
Yeah.
for this under expanded stent.
How many pulse did you do?
I gave all the 80 shocks, all the shocks
Okay.
throughout the length of the stent.
Okay.
Very nice.
Thank
case.
you. Thank you very much.
Thank you. And next case is a 3-in-1 case, all right? Total occlusion, bifurcation, and multivessel PCI. It will be presented by Benjamin Tao or Shun Lim. My pronunciation correct? I'm sorry.
Thank you for the introduction. Good morning to all the panelists. My name is Benjamin Lim. I am from Hospital Serdang in Malaysia, and my case is entitled a 3-in-1 case, a total occlusion, bifurcation, and multi-vessel PCI. I have no disclosures for this presentation. My patient is Mr. SBC. He's a 60-year-old gentleman with no known medical illness and has been vaccinated against COVID-19. He presented in July 2021 with typical chest pain and shortness of breath. His vital signs were stable, physical examination was unremarkable.
ECG on presentation revealed the ST segment depression over inferior leads with dynamic ECG changes present over the lead 1, AVL V2 to V5, showing ST depressions. His cardiac troponin level was 85 nanograms and elevated. His creatinine was normal with a GFR of 79. His echocardiography revealed an ejection fraction of 52% with mildly impaired systolic function. He was admitted, diagnosed with a non-STEMI. A coronary angiography was then arranged for him. This is the image of his coronary angiography, and this is of the left system. You can see that the left, the circumflex is relatively spared. There's a minor disease, but otherwise there's an ostial LAD, about 50% stenosis. The proximal LAD is CTO. Ostial diagonal actually has disease here as well. But also there's a very tight lesion over the proximal diagonal 1 and a medial 111. So looking at his right coronary artery, Looking at his right coronary artery, it's a dominant vessel with also a very presence of a very tight stenosis over the proximal to mid areas, and also presence of disease over the crux and also the PDA as well present. Looking at his CTO score, it's actually 0. So after discussion with the patient and looking at his angiograms, we actually decided that we would intervene and perform a PCI to LAD, his diagonal and also his RCA as well. We used the right femoral approach with a 7 French sheath, EBU 3.57 French guide catheter for the left system. We put a cyan blue wire and placed it in a fine cross microcatheter and was able to actually advance it down to the distal LAD. And we did pre-dilatation with a semi-compliant 2015 balloon. And we also wired the diagonal with the BMW wire, and also used the same balloon to actually pre-dilate the diagonal. And these are the images post SC balloon, semi-compliant. You can still see some residual stenosis present there and a bit of a dissection. We did further pre-dilatation of the LAD and diagonal with a bigger balloon. However, this time we used a non-compliant 2.515. So this is over the LAD, and on the right here is over the diagonal. And these are the images post-ballooning. And you can see that we placed, we decided to stand the mid-LAD, mid to proximal here. And we went up with a drug-eluting stent 3.538 millimeters. And after which we did an overlap stent to the ostial LAD with a 3.5 millimeter to 20 millimeters length. And we deployed it there from the caudal view. And we did further post-dilatation with the stent balloon over the overlap segment, followed with a NC balloon, a non-compliant balloon, a short NC balloon, 408, up to about 20 atmospheres over the proximal segment of the stent. Then we rewired the diagonal, and we followed that with the first kissing balloon inflation with a semi-compliant 2.0 at the diagonal, and also another with a 3.5 NC, non-compliant in the LAD. We followed that with a drug-eluting stent placed in the diagonal, a 275 22 millimeter, and we perform a TAP stenting. So you can see that there's another balloon there, 3.5 NC balloon there in the LAD, and also we deployed the stent here. And followed that with the second kissing balloon inflation, 3.5 in the LAD, and using the stent balloon. These are the images that you can see after we have actually done the kissing. And this is the final angiograms that you can see present over the left side. There's good flow down the LAD and also the diagonal. No dissections noted. No slow flow TIMI3. Then we went on with the PCI to the RCA, and we used a 6 French 3.5 JR, wired down with the cyan blue. Pre-dilated the PDA with the 3O NC, and a 3.5 used to pre-dilate the RCA with a 3.515 up to 20 atmospheres. And these are the images post pre-dilatation. You can see that there's quite a lot of recoil, plus there's a little bit of a the vessel here, the sizing. This one, the recoil is not too severe, so we decided to proceed with the a DEB, a long DEB to the PDA from the crux, 3.540, and we delivered that for about 60 seconds at about 10 atmospheres. There was a type A dissection noted over the PDA. However, the flow was non-flow limiting, so we decided to just leave it alone first and proceed with the PCI for the proximal to mid segment of the RCA. And we put a stent 4022 delivered at about 18 atmospheres over that segment. Post-dilated the segment with the 4.510 non-compliant balloon up to about 20 atmospheres. Right? However, because this dissection seemed to be worsened, we actually decided to stent across the dissected segment here, and we placed a 3O 26 millimeter stent. It's kind of a large stent, even though it's a RPDA, a 3O 26 delivered at about 12 atmospheres. And this is the final angiograms present over the right side. You can see the stent here, well expanded. So the initial use of DEB for the RPDA was made due to the distal location of the disease. However, the dissection seen in the post-DEB altered the plan and caused us to use a DES. Would you have done it differently and perhaps stented the vessel directly? Next, would you consider performing a DK crush bifurcation stenting or perform a provisional stenting as was done in this case? We opted for a provisional stenting in this case as it simplified the procedure, reduced the time, radiation and contrast use, bearing in mind our plan to revascularize the RCA concomitantly. In conclusion, multi-vessel PCI may be beneficial to patients and treating hospitals if done well, as it offers potential cost savings on equipment, repeat procedures and admissions. However, appropriate planning and strategy should be employed to reduce the risk of contrast-induced nephropathy and radiation. The appropriate size of guiding catheter must be considered when there's a potential for bifurcation stenting to accommodate equipment delivery and for kissing balloon inflation. And in this case, a 7 French guide aided delivery of equipment and made the procedure smoother. Thank you.
Okay, thank you for a wonderful presentation. So this is open for discussion. Any question or comment from the panel? He listed some discussion point, right?
Yes.
Okay. Are there any comment to the discussion point?
I think if you did proximal optimization before the rewire the diagonal branch. Maybe I will do a rewire the diagonal branch first, then proximal part high pressure dilatation, because the proximal part high pressure dilatation can compress the jailed side guide wire that can cause sometimes a problem. The second thing is this case is the diseased diagonal ostium. The angulation is not so wide, so therefore tap techniques may remain the protrusion of the stent at the proximal part. So if I were the operator, I'll choose clash crushing or TK crushing instead of tap technique, maybe.
Okay.
Dr. Benjamin, I have one question for you.
Sure.
And a previous session, you put the LAD CTO put the wrong standing previous session.
Yes, yes.
Yeah. So I wonder, diffuse wrong lesion, you prefer DCB, drug coating balloon, prefer to drug stenting. Which you personally treat?
Sorry, I'm a bit confused. Could you repeat the question?
This is a question for the previous case, previous session case.
And generally, diffuse wrong lesion.
Long lesion.
Yeah, coronary diffuse wrong lesion.
Yes,
Particularly-
sometimes we do combine hybrid. That means we do for the distal lesions, we actually do DEB, and then for the more proximal lesions, we actually go up with a stent. But also looking at the lesion morphology and whether or not the dissection is present after the lesion preparation is done, then sometimes we decide based on that whether or not to stent or whether to put a DEB.
Yeah, generally agree. But the DB should be effective for the smaller size. So it depends on the size of the vessel, right? Okay.
Okay, because time limitation, it's time to move to the next case.
Thank you very much.
Okay. The final case is entitled Proximal LCX CTO and Tortuous Proximal LAD, Rotational Atherectomy and Left Main Bifurcation Stenting with Provisional Stenting to LAD D1 Bifurcation. This will be presented by Jonathan Shingo Fang, please.
Thank you. So I have a very long title. It's essentially a CERT CTO left main LAD disease case. So nothing to disclose. So the case is a 78-year-old man, BMI of 27, ex-smoker, presenting with 1 month history of recurrent angina, CCS class 3, worsening dyspnea, and heart association class 2 to 3 for 1 month, and had an echocardiogram showed preserved EF, some degree of mild aortic stenosis, aortic regurgitation. EKG essentially shows no Q wave. Chest X-ray is clear, troponin not elevated. His creatinine is in the upper range of normal limit at around 120, 130 micromoles per liter. And he has had a suboptimal least stress and nuclear stress test, which already showed infralateral large area of ischemia with post-stress EF of 45%. So previously, he has received a stent to the circumflex artery around 10 years ago, and at another institution, and he also has atrial fibrillation and is currently on apixaban, and he has now also on aspirin as well. For comorbidities, his hypertension is well controlled on 3 antihypertensives, lisinopril, metoprolol, and hydrochlorothiazide. He has COPD, which is controlled by albuterol inhaler, and also benign prostatic hyperplasia on tamsulosin and finasteride. No allergies. This is his EKG, no QA, but we see some degree of interventricular conduction delay, a tall RF transition, and this QR, perhaps a left posterior vesicular block here. And we cannot completely exclude inferior infarct, but on the nuclear stress test, we know that it's viable. So this is the angiogram done at another institution. It's an interesting finding here is that the disease in the circumflex, and there's also some fistulization to the coronary sinus, although we can't pinpoint where exactly the fistula is. And the LAD is tortuous and also with diffuse disease. So this was 1 month, then 1 month before procedure. You see this, there's a high OM here, this disease, this CERT into OM. It's all disease, there's a stent here, and ISR. And since this angiogram, his disease has actually progressed. The right essentially is a moderate disease in PL branch, especially. It could be significant, actually. So we had a CHIP consultation initiated, calculated the syntax 2 score. The syntax 1 was in the range of around 45. Syntax 2 is 57 for PCI, 59 for CABG. And this leaned towards PCI mainly because of the COPD. So opted for PCI. So first we performed circumflex PCI with several French radial system, but because of tortuosity, it wouldn't go. So we switched to a sheathless PB30 guide, which didn't offer great support. We wired both the circumflex and LAD, and used a turnpike LP microcatheter to increase support. But the balloon would not cross. So we switched over to femoral access and had an 8 French system together with guideliner support, and we were able to wedge the microcatheter and exchange to a rotor wire. And then we perform rotablation of the stent, and we use a higher RPM at 200,000 for this instant to ablate neoatherosclerosis. And after that, we took care of the under expansion by calcification by IVL, lithotripsy 3.5. And we always follow them by the pressure with NC balloon, high pressure ablation. So this is the lithotripsy, and this is the IVIS post rotational atherectomy and lithotripsy, giving us a satisfactory result. And we can see some crack of calcification just proximal to the stent. So we were able to land 2 stents, 2 538, actually it was 3 533, to stent into left main. And at this point, we completed the revascularization of the circ, and we used 125 mils of contrast, but the radiation wasn't great. It's almost approaching 2 grays. So we decided to stop here and bring him back for a stage procedure to the further work on the left main into the LAD. And indeed, in those 3-week time, he had persistent chest pain. So this time, because of the complexity, we decided to get anesthesia support. Did the case under MAC and upfront femoral access. Here we use EBU 35 a French guide. We appreciate some degree of left main disease, more than 50% here. And the LAD is very taut to us, almost there was a loop here on this previous shot. And we couldn't deliver any kind of imaging catheter down the system. But we were able to wire it and exchanged with microcatheter to rotor wire floppy. And again, we used 175,000 rotations. We always pre-treat with aminophylline to prevent bradycardia, even in LAD. But in this case, he developed a profound bradycardia, so we needed to put in a temp pacing wire. And we proceeded to atherectomize the calcified diffuse disease in LAD. And then we did lesion preparation, NC balloon 2530, as well as scoring balloon, all at high pressure up to 20 atmospheres. And then we landed 3 stents, 3038, 3033, and finally 35 for 15 into the left main LAD. And we essentially, the technique for the left main bifurcation was a completion reverse culotte. And this was a port 4.0. We rewired, did some post-dilation, rewired the circumflex over a microcatheter turnpike LP, which to increase the support and increase the ease of rewiring, dilate up to NC 3.0, and then did the kissing balloon inflation with 3.5 in LAD and 3.0 in circumflex. So there was a high diagonal that we didn't really pay too much attention to. Its ostium was actually 50% disease. And in some of the work with the kissing balloon in the post-dilation, there was jeopardization of the flow in the diagonal. And patient has chest pain as well as ST elevation V1 to V3. Refractory to medication. So we had some hard time trying to rewire this. We were able to do it with a Suzuki wire, with a pilot 50 wire. So we ballooned it up, but the symptom persisted. So we decided to do a tap stenting with a 2.5 stent over there. And did a kissing balloon 3.0 LAD 2.5 in the diagonal. And this was the final result that we got. And so this case illustrates several areas that can go wrong. First is the access problem. We had to switch to the femoral. We had to go in with a railway. Some other alternative is use a balloon assisted tracking to go up the radial, but it still does inadequate support. We eventually needed to switch to femoral. Uncrossable lesion. that required wedging of microcatheter, exchange of rotor wire. Sometimes these lesions require upfront atherectomy wiring, which is usually easier with the orbital atherectomy than the rotor because of the size of the larger micron of the wire. And the bradycardia required 10 pacing wire. And the recoursing of the circumflex required microcatheter support. And also the side branch was jeopardized, which required dual lumen catheter and hydrophilic wire for wiring. And so one case in retrospect I didn't do was we actually anticipate some degree of deterioration. If the patient had a lower EF, I wouldn't hesitate to also gain contralateral femoral access and have a placeholder in case the patient needed mechanical circulatory support. By placeholder, I don't only mean access, which is not quick enough, but actually a pigtail into the LV. If the patient deteriorates, I can immediately switch out and then upsize and then put an impeller in. And with these considerations, I could conclude my case.
Okay. Thank you very much. So this is open for discussion. Any comment?
A very expensive procedure.
Yes, it was totally covered by insurance in the US.
Yeah. But it's demonstrated that actually if you have all kind of resources,
Yes.
you can have an excellent result. So that's the only conclusion I can say.
Thank you.
Okay. Any other comment?
Treatment by cell region with the DS is very nice, and congratulations to your new stand in the circumflex. But I think the runoff of the RAD is very good. So how about the minimal invasive bypass surgery in this case?
Yes, we had a surgical consult where CHIP consult always involved the surgeons, but because of the COPD and patient family preference, usually they prefer PCI. So overall, then we opted for PCI. There's a very in-depth discussion that's also well documented. We always document the peri-procedural risk as well as the one-year mortality predicted.
One comment from me is the simple side branch opening is not a good technique because I'm wondering, it depends on the wire position, but strad goes up to the main branch. At that time, sometimes if you try to push in the other device, balloon or imaging device, it may have the risk of stuck, right?
Yeah,
But
we had an A-French system in retrobest. We could have used something like a modified gel balloon.
Okay. Any other comment? If not, yes.
Thank
you very much. So some closing remarks. Yes, please.
Thank you for everyone for participating in this session as it's time to close. Thank you, everybody.